affecting newborns and our older patients. And in some studies, it's been estimated that, at least in the pediatric intensive care nursery unit, it's the second most common infection that is seen in that population of patients. It's very difficult to determine the exact rate of ventilator-associated pneumonia in newborns, mainly because the populations are so different. People have different criteria they used, and it makes the diagnosis very difficult. I think as neonatologists, and I'm sure as intensivists, we have a very low threshold to making the diagnosis, and in a patient who is ventilated and who suddenly is not improving or getting worse, we get a tracheal aspirate, and if it's positive or if we're concerned about the number of organisms, we are very inclined, or we may be very inclined, to start antibiotics in the face of a disease process which may or may not be a ventilator-associated pneumonia. The case mixes have changed quite dramatically. In those people reporting the incidence of ventilator-associated pneumonia, populations of patients different, hospitals are different. In one study done in the United States by the National Nosocomial Infectious Surveillance System in 2004, they estimated that in babies weighing less than 1,000 grams, the incidence of infections ranged somewhere between 2.4 and 8.5 episodes for every 1,000 days on the ventilator. Other studies report much larger incidences of infection, some studies as high as 40 or 50 episodes per 1,000 ventilator days. It was a very interesting study I came across in reviewing for this talk that looked at a nursery, a neonatal intensive care nursery, which was adjacent to a pediatric infectious disease ward, and they noticed in that population of newborns, the rate of ventilator-associated pneumonia was quite high. When they moved the nursery to a new location in the hospital away from the infectious disease ward, the incidence dropped to much more normal levels. So it was clear in that situation that probably there was a fair amount of cross-contamination between personnel going from one unit to the other. Mortality rates can be quite significant in patients who develop ventilator-associated pneumonia. In some studies, the incidence has been reported up to as much as 10%. And it's well recognized that patients with ventilator-associated pneumonia have a much larger morbidity in addition to their mortality. They spend longer amounts of time on the ventilator, higher exposure to oxygen, much more time in the intensive care nursery, a higher exposure to antimicrobials, and of course increased indirect medical costs. In our country, there's a movement toward not paying for conditions such as this, which may be regarded as never events. In other words, the insurance companies are starting to look at problems such as ventilator-associated pneumonia, considering it a preventable illness, and are, I think, working toward not covering these kinds of patients in the future, and maybe even at present there may be some rare episodes of not covering these patients. What are some of the risk factors for ventilator-associated pneumonia? I think some of the most important ones, at least for babies in the neonatal intensive care nursery, are their low birth weight and their prematurity. We know as neonatologists that the premature baby is at particular risk because of an immature immune system. Virtually every aspect of their immune system is compromised. They have poor white cell response to infection, decreased complement. As a consequence of being born prematurely, they have lower antibody levels, less likely to get IgA transfer from the mother who might be breastfeeding. These babies, particularly the very small ones, are subjected to mechanical ventilation. They, again, particularly the ones at the limits of viability, the 24, 25 weekers, 26 weekers, are subjected to prolonged periods of ventilation. They receive opiate sedation, and I think as a consequence, this drug may interfere with their ability of the cilia to clear secretions and mobilize secretions, as Rob indicated in the last presentation. These babies require frequent suctionings, which may introduce contaminated material. They require reintubation over the course of their time on the ventilator. Enteral feedings may contribute to infection, particularly in babies who have frequent episodes of aspiration or regurgitation into the oropharynx, and these gastric contents may find their way into the airway, and in particular in the newborns who are being ventilated with an uncuffed endotracheal tube. Crowding occurs in many nurseries, I'm sure not only in your country, but in our country, and when there's crowding, we know that there's an increased incidence of contamination between the caregivers who are taking care of multiple patients in the intensive care nursery. Nurses who witness aspirations have been associated, or at least the aspiration episodes have been associated also with increased incidence of ventilator-associated pneumonia. And then lastly, a very important contributor to this is poor hygiene, primarily by the caregivers, nurses, respiratory therapists, doctors who are caring for babies who are not either taking care of the equipment or, perhaps more importantly, not washing their hands prior to moving from one patient to the other, or making an intervention such as suctioning or changing an endotracheal tube. The ventilator-associated pneumonia occurs in situations where there is invasion of normal lung parenchyma in a patient on mechanical ventilation. It typically occurs from aspiration of contents which are in the oropharynx. There was some work that looked at the potential of pneumonias being caused as a consequence of aspirated materials in the stomach or the aerodigestive tract, and I think more recently it's been shown that these may contribute to infections, but certainly are the cause of the minority of infections that we see, at least in the newborn nursery population, and most of the infections are caused by aspiration of material in the oropharynx or by contamination from caregivers, as I mentioned before. The organisms that we are likely to see in these patients are termed as either endogenous, meaning that they are on the patient, in the patient, or exogenous, those organisms which are brought to the patient from outside sources such as visitors, caregivers, or contaminated equipment. To emphasize that endogenous organisms are those which are typically found in the upper respiratory tract, and as I indicated before, pooled secretions, particularly in a newborn infant, creates additional risk because of the uncuffed nature of the endotracheal tube and the likelihood that these secretions can find their way directly into the lung. I must stress, too, a lot of this data is obtained from adult populations, and we as neonatologists, and I think also as pediatric intensivists, have extrapolated a lot of our information and our treatment and preventive modalities from work done in adult populations. We can think of the organisms as being either gram-positive or gram-negative. The gram-positive organisms, such as Staph aureus, tend to occur early in the infection, whereas the gram-negative organisms, such as Klebsiella and E. coli and Enterobacter, occur later in the course of the patient's illness. And as you can readily appreciate, and I'm sure in your experience you find that more often than not we find polymicrobial organisms in our culture material, particularly in my experience in the neonatal intensive care nursery. We get a suction material from the either the oropharynx or the endotracheal tube, and more often than not there's a whole host of organisms which may be identified. That, of course, makes diagnosis much more difficult. The ventilator-associated pneumonias occur again when organisms enter a normally sterile lower respiratory tract and infect the normal lung parenchyma, particularly in patients who are vulnerable. In those of us who are healthy, we have the ability to protect against such infections if we should inadvertently aspirate material into our airway. And when, again, particularly in the compromised neonatal patient, the small baby, the premature baby, when the defenses are compromised, pneumonia and pneumonitis is much more likely to occur. I mentioned that gastric flora may be involved in the course of infections, probably not as commonly as what was once thought, but we may influence the ability of gastric contents to cause infection by the use of medications. Those medications which may alkalize the gastric contents may promote organisms to grow in the stomach. Positioning the baby or the older child may have an effect on on the likelihood of aspiration, and that's why I think particularly in older patients, less easy to do in the newborn is to try to ventilate these babies somewhat with their head elevated, so we decrease the likelihood of aspiration pneumonia. And again, to emphasize that most of the more recent studies show that the vast majority of infections are caused by either oropharyngeal colonization than aspiration of gastric contents. And it's been shown that very rarely do the organisms enter the lower respiratory tract by either bloodstream or, again, bacterial translocation from the baby's gastrointestinal tract. Ventilator-associated pneumonias are much more likely caused by gram-negative organisms versus gram-positive. Very difficult, again, as I alluded to before, to get good data because the cultures, particularly in newborns, are oftentimes contaminated, and we don't have the ability to sample the lower respiratory tract as we do in older children, and particularly adults, where we can get sometimes a very much more accurate sample of what may be happening in the lung. We think that particularly in newborns, if the colonization count is greater than 10 to the fifth, this has a much higher association with ventilator-associated pneumonias than would be other colony accounts. And this number of colonies would tip us into probably deciding to start broad-spectrum antibiotics. It's well known that the endotracheal tube may serve as a reservoir for infection, and I think Rob showed us a picture of a contaminated endotracheal tube, and I think it's very easy to see how organisms may become colonized on such a tube and lead to infection. Rob also alluded to the potential for ventilator circuits to become infected, and I think outlined some of the ways that we can prevent infection by keeping ventilator circuits free of water and heating and humidifying the oxygen. Well recognized that contaminated equipment can be a very important source of ventilator-associated pneumonias in babies. Probably, again, the most important cause of infections is related to exogenous contamination from the caregiver, visitors' hands that may introduce organisms to the patient in the intensive care nursery. And that's why, as we'll see in a few minutes, it's so important to have policies which institute a strict hand washing and strict adherence to good infection control measures. How do we make the diagnosis of ventilator-associated pneumonia in the baby? It's very difficult. Most people would agree that there are certain criteria which must be found before the diagnosis can be made, and I would be the first to admit that we don't always adhere to these criteria, and we have a very low threshold, at least in our unit, for treating patients appropriately or not appropriately with antibiotics, particularly if they don't meet all these criteria, but if we have the clinical impression that the patients are not improving on our therapy. But what some of the proposals that have been published in the literature would indicate that in order to have a ventilator-associated pneumonia to make the diagnosis, you must have temperature instability with no other explainable cause, white counts which are exceedingly low, less than 4,000, or those which are exceedingly high have been associated with pneumonias, a change in the character of the sputum, increased respiratory secretions, the need for frequent suctioning should be present, apnea, tachypnea, nasal flaring or grunting, which is new, should be present, wheezing, rales, rhonchi, or cough, bradycardia less than 100 beats per minute or greater than 170 beats per minute also should be present. And you should have at least, I think, 3 of these present in order to make the diagnosis. And again, recognizing that the criteria for neonates has not really been validated. I think those criteria which I just presented to you are more relevant in older children and adults than they are to newborns, but that's the best that we have. And it's oftentimes difficult to differentiate between a true and a pneumonia. No clear consensus on how we use these guidelines to make the diagnosis, but again, I think most of us, at least in the neonatal intensive care nursery, would feel that if we have the clinical impression of a ventilator-associated pneumonia, we would approach it by adding broad-spectrum antibiotics to cover gram-positive and gram-negative organisms. What has been particularly helpful in our hospital, in our children's hospital, is the infection control people publish periodically the types of organisms which have been associated with a variety of infections in our hospital, bloodstream infections, ventilator-associated pneumonia, and knowing that may help you decide on what antibiotic choice to select when it comes to choosing which antibiotic to use. How do we develop detection strategies and methods of surveillance? Certainly active surveillance protocols are needed to accurately identify patients with VAP. The criteria may vary from nursery to nursery, but typically involve looking at chest radiographs and looking for evidence that is consistent with pneumonia, consolidation, infiltrates, gram staining, and cultures of the endotracheal secretions or specimens obtained through bronchoalveolar lavage. Again, typically not done in patients in our intensive care nursery. Again, to emphasize that many of these studies have been done in adult populations, and I think we have to extrapolate our treatments and our approach to these infections based on adult data. The recommendations are designed to interrupt the 3 most common ways these infections occur, namely through oropharyngeal infections, the transmission of organisms through the caregivers, and less likely through gastric contents. We recognize that, at least in our nurseries, orotracheal intubation is preferred to a nasotracheal intubation, and nasotracheal intubation has been associated with sinusitis, which may increase the risk of ventilator-associated pneumonia in newborns. We suction out the oropharynx around the endotracheal tube before extubation or adjusting the tube or removing the tube, and this may help the inadvertent aspiration of infected material during the process of tube removal or after the endotracheal tube is used. People have looked at closed systems, use of multi-use catheters, for suctioning, which allow you to suction without disconnecting the baby from the ventilator versus traditional ways of suctioning. And to my reading of the literature, and maybe Bob would have some comments, since I don't think there's much evidence to suggest that one method has much of an advantage over the other, although I must admit in our nursery we do use a closed system for suctioning our patients. Bob mentioned the ability of condensation being a source of infection, and we certainly recognize the need to look at the ventilator tubing periodically to remove any pooled water that collects in the dependent areas of the tubing to prevent infection. We drain it away to prevent infection, and it's not recommended that we change the circuits very often. And I think in our nursery several weeks go by before we change the ventilator, these heated ventilator circuits, and I think as long as even a month goes by before we change these circuits in our patients. Other methods of trying to prevent ventilator-associated pneumonia involve close assessment of the baby on at least a daily basis to assess their readiness for extubation, and obviously an extubated patient is much less likely to develop a ventilator-associated pneumonia than one that is subjected to an invasive ventilation. We try to avoid over-sedation, which may interfere with the ability of babies to clear secretions. There's certainly been a move, and we'll hear more about this later this morning and this afternoon, about, quote, non-invasive therapies to ventilate patients, nasal CPAP, nasal prong ventilation, to cut down on the incidence of bypassing the epiglottis, and hopefully not only at preventing lung trauma, but also decreasing the incidence of associated pneumonias that are associated with intubation. And again, avoiding reintubation and trying to manage these patients with CPAP or some other forms of non-invasive ventilation. It's been suggested that acidification of the gastric contents may decrease colonizations. I don't think this has necessarily been shown to be effective in newborns and some older children, but perhaps in adults. It's been suggested that medications such as some of the H2 blockers, H2 antagonists, may increase gastric colonization by increasing the pH of the stomach and therefore allowing organisms to grow. Current data does not advocate the use of peptic ulcer prophylaxis in newborns for the prevention of VAP. It's been suggested that lateral positioning of our patients, particularly in the newborn, may decrease the incidence of ventilator-associated pneumonia. And I think the rationale there is that by putting the baby on a side, you're less likely to have drainage from the circuit and from the endotracheal tube and from the oropharynx go down into the airway. And there's some suggestion that keeping the endotracheal tube in the circuit in the horizontal position may decrease the incidence of ventilator-associated injury. Hard to do in the newborn period, that is to keep the baby in the semi-recumbent position. Probably a lot easier to do in older patients and adults. We want to avoid gastric distension, which might increase the likelihood of aspiration of gastric contents. Many of these patients that we manage in the nursery have a nasogastric tube to prevent this from happening. And certainly to try to avoid unplanned extubation and the necessity for reintubation. We have protocols set up, taping maneuvers, maneuvers that secure the endotracheal tube, which have been in place for several years, which have decreased the likelihood of unplanned extubations really quite dramatically in our nursery. Non-absorbable antimicrobials and topical antimicrobials that can be applied in the oropharynx to decrease gastrointestinal colonization or selective digestive tract decontamination might prevent the incidence of, or increase the incidence of VAP in our population. But I think further studies are needed before we can advocate the use of these medications and in at least our newborn population. Adult populations have been using chlorhexidine rinses in the oropharynx, which seems to have decreased the incidence of ventilator-associated pneumonias, but I think the current literature would indicate that it's not been advocated for use in newborn patients. I mentioned the importance of orotracheal intubation. We want to use sterile water to rinse reusable respiratory equipment and to keep it clean. Reinforce the importance of removing condensed water from the circuits. Keep the ventilator circuits closed so we avoid contamination. Change the circuit only when it appears malfunctioning or visibly infected, and store the equipment in a appropriate area where it has a decreased risk of getting contaminated. Again, in closing, really to stress the importance of good hand hygiene, give the nurses and the managers in your nurseries and your PICUs the authority to remind somebody to wash their hands, particularly some of our surgical colleagues who feel that they have the right to come in and examine patients without washing their hands, that they're not contributing to infection. And at least in our nurseries, the nurses have the ability to grab that surgeon by the hand or to stop him before he touches the patient and tells him to wash his hands before examining that patient. And to stress the importance of developing institutional policies in your hospital, in your nurseries, in your PICUs that can go a long way at decreasing these infections. We have special nurses that make rounds on a regular basis, infection control nurses, nurses in our nursery, and I'm sure in the PICU collect data on the incidence of infections, and we use that data on a regular basis to strengthen our protocols at trying to decrease infections. We conduct active surveillance, use non-invasive ventilation wherever possible. We want to minimize the duration of endotracheal intubation, perform daily assessments to assess the baby for their readiness to wean and come off the ventilator, and to have continuous education for the healthcare personnel, the nurses, respiratory therapists, neonatologists, pediatricians, anybody, residents, anybody who's coming in the nursery about the importance of hand hygiene and good techniques. And again, the judicious use of antimicrobials, not only on patients who are ventilated, but those babies who are in the intensive care nursery. And I think we've got to avoid this policy that I think is all too prevalent, at least in our hospitals, to start everybody just because they walk in the door of the intensive care nursery to be put on a antibiotic. And I think we as neonatologists, intensivists can probably be a little bit more careful as to who we decide needs an antibiotic and who doesn't. We want to employ strategies that reduce bacterial colonization, recognize the potential for the endotracheal tube to be a source of infection, position the baby, mouth care, nutrition, and again to stress the importance of quality improvement techniques which are ongoing in our hospital, in our nursery, to make sure that we're adhering to all of our policies. I think in closing, I would say that certainly prevention is the best policy rather than trying to treat these infections. And I think perhaps the most important recommendation that I can make is to enlist the help of the hospital administration to support these protocols, to hire infection control nurses, and to really get behind those of us taking care of patients in supporting surveillance techniques and infection control techniques that are likely to decrease the incidence of these potentially life-threatening and certainly infections which cause considerable morbidity in our patients. Thank you very much.
Thank you, sir.
So that's how you decrease the risk of ventilator associated pneumonia. To utilize, just eliminate it with that step. There are some patients also that you have to be careful of. It's dangerous to put somebody on this
So you can feed your
kind
pediatric
of
patients
support if they don't have
pediatric transport options. So you can feed your patient and then so you
you
have
have to
less
be careful
in the system.
have
So
an
it's going to
open
be in the retrocardiac space.
oxygen airway, otherwise this won't work. And if the patients can't
to the
do
beam.
their secretions,
In order
this
to
is kind of a dangerous modality. So if
insert,
somebody's neurologic
as you work
status
the
is
normal
depressed,
nasogastric feeding tube,
this is not a good modality. If somebody just has neuromuscular
insert.
weakness, still has
the next thing we're waiting for that balloon to be in the retrocardiac space. So you'll have
not very high support.
waveform.
Let's see, some practical
Show you
things.
cardiac oscillation.
You have to select the mask carefully, and there are different size masks for different types of patients. And the device may either just cover the nose, or it may cover the nose and the mouth. And it's probably better to use nasal positive pressure if you can, rather than both nasal and oral, because if the patient vomits, they still can do that. It's just a nasal device. The face is covered with a mask. And then
reasons for doing a cesarean section prior to euthanasia. We recognize that there are certain strategies that can be brought to the mother that can decrease the likelihood of premature delivery. Antibiotics in the face of a urinary tract infection, a bootstrap infection, steroids.
But there are some ventilators that are available that have this technology, but it might be slightly different from what's provided by this oscillator. This oscillator is 3100A by Sensormedics. What we have here is, this is the ventilator column, this is the ventilator head, and really if you were to open this up, it looks like a radio speaker in there. So this is all contained within there. There's a cooling system that keeps the piston nice and cool, and that piston's going to beat back and forth. Well, there's a fresh gas that's going to come from the humidifier. We're always going to make sure the humidifier is on, right? So the fresh gas comes through the humidifier, goes into the inspiratory limb. This is your inspiratory limb right here. This is the temperature probe, right? And that gas is going to come through the system. There's a bias flow of gas going through that system at all times. And that bias flow in babies, you shouldn't have to set that at more than 15. For years, we were always told, set your bias flow at 20 liters a minute. However, if you set that too high, it may result in gas trapping in your baby. So what I tell people is to use the lowest possible bias flow. That's like your CPAP gas going through the system. Use the lowest available bias flow to maintain the pressure that you want to set. Now, if the baby wakes up and is breathing, you may need to increase that bias flow a little bit to keep that pressure constant. Otherwise, the alarms will be going off, and you won't have a stable mean air pressure being provided to the lungs. So the bias flow, generally speaking, is 10 to 20 liters a minute. Larger patients, you need that higher bias flow to maintain. We're going to make adjustments in that CPAP, or the mean airway pressure, to try to enhance lung recruitment. We want to try to optimize and maintain the lung volume, and that's all going to be based on X-ray. It's going to be based on PaO2, saturations, and the amount of FiO2 that the infant requires. Okay, so initially we're going to start that a little bit higher, but it isn't going to take long before the lungs start to open, right? And especially now that you're ventilating at these itty-bitty tidal volumes, you may reduce inflammation, you enhance surfactant production in the lung, so the lungs will open, and you'll get really good gas exchange. You'll know that the lungs are opening when you can wean the FiO2 down, and their saturations are going to stay the same. All right, so it's something. The second you put someone on an oscillator, always be vigilant about and cognizant about weaning the FiO2 down as quick as possible. Right, and then once you're able to wean the FiO2 down, then you know the lung is opening. So then you need to start weaning the pressure back to overcome, so that you don't run into the problem of excessive alveolar overdistension, and that can become a problem. So that's your mean airway pressure setting, and we'll talk about scenarios today on how to manage patients that are receiving high frequency oscillatory ventilation. Oxygenation, let's talk now about ventilation. Ventilation is determined by two things. It's by your delta P, all right? So you think of that as your change in pressure. Your delta P, which is adjusted by the power setting, right? And that is the pressure change that occurs when we
Intubation.
the trough.
I don't think we would let the baby get so bad. I don't think we do them necessarily every 10 or 15 minutes. Typically what we
That's
do,
how you know that the baby's wiggling well. Now, if that wiggle goes away, what's happening? Well, they've either got a pneumothorax, they've got a mucus plug, they have something going on, and it's always important to not only monitor their chest wiggle, but also to look at an occasional blood gas. Or if you have the ability to measure transcutaneous CO2, right? So as you increase the delta P, you decrease the carbon dioxide level in the lung. Don't be afraid to turn that up. Keep turning it up. All right, don't worry about that so much. Percent inspiratory time, I would not change that. I wouldn't change it at all. In fact, the only time I've ever changed this percent inspiratory time, this helps us to determine our IDE ratio. The only time I changed that was in a very sick adult that I couldn't manage. And by turning this up, we kind of changed the characteristic of the pressure profile that's being delivered into the lung. And the distal alveolar pressures could more approximate what's going on back here. But keep in mind, this should not be set or adjusted. You can do everything you need to do with this at 33%. And also keep in mind the pressure, that pressure is being measured downstream here at the patient Y. Now, the last setting on the ventilator is going to be your frequency setting. And this is where most people become confused. If you can overcome this simple terminology, you'll understand high frequency oscillatory ventilation. Most babies, most premature babies, we will start their Hertz setting at around 12. If they're low birth weight babies, we'll start them at 12 to 15.
10 minutes of age and
Their
10
Hertz
to 12
setting.
hours of age.
If they're term baby,
One thing that we have instituted years ago is having a special team available to go to the delivery room. A neonatologist, a pediatric resident, a nurse practitioner, a respiratory therapist, and another nurse. So there may be 5 people who can help you. The neonatal, sometimes the resident will intubate. We supervise. The respiratory therapist is attaching the pulse oximeter and managing the oxygen. The nurse is measuring the heart rate and listening. So we work as a team, and it's very, very helpful. You've heard of the golden hour, right?
How often you take an X-rays? You take it routinely or?
We do take an X-ray routinely, typically not necessarily before intubation, but we try to save the baby's extra X-rays by putting in an umbilical catheter, and if we intubate, then we get an X-ray so we can at least see the position of the catheter and the endotrachea, so we get kind of a film from here down, and sometimes a lateral film as well. And we have a portable, these are portable films. The X-ray machine comes up to the unit, so it's very easy. And this is to your point, early treatment better than later treatment. Lots of articles which have shown that the earlier you give it, the better. It's a 2-person operation. Again, nice to have a team. Here's what you need, a tube, a surfactant, a catheter, a feeding tube, tape measure, gloves, and you want to confirm the position of the tube. Not always possible getting an X-ray in the delivery room, but we listen. We have CO2 detectors. Do you use CO2 detectors? Yes. So we're pretty good at determining if our tube is in the right position. We listen both sides. We have the CO2 detector, and we can see if the baby's heart rate is responding. And we feel pretty confident when we give the surfactant that the tube is in a good position. It's not down one side versus another. Sometimes it happens, but we try to avoid that. So it's injected into the ET tube. We use a neopuff during our resuscitation. Our policy is to give half a dose and turn the baby to the right side. ventilate, then give the other half to the other side, hopefully getting it down the right mainstem bronchus and the left mainstem bronchus.
And what are the initial pressures you would...
So the latest, Dr. Carotene, the latest recommendation is that there is no need to change
I know
the
that, yeah.
Closer.
We are following
It's
the-
very liquid. You just have to instill.
Yeah.
We are just following
I
it in the
understand,
point.
yeah. I recognize that. For some reason in our nursery, they are still turning the baby.
Okay.
I know it's not necessary to do it, but that's what we've been doing.
Because we have stopped
Yeah,
doing that
I think it's
almost
okay. Yeah, I think
6,
it's
7
okay.
years before.
I've worked in other nurseries where they do that.
Go to the next one.
So what I'll show you right now is what a lung looks like. This is a lung right here that is surfactant deficient and doesn't have any gas in it. But as we start to apply meteoric pressure, you can see that the lung is going to start opening. Turn on the picture. Remember, this is a labor of love. This is going to be a labor of love. We'll just pressurize it for now. You turn the pressure up. So this one's stuck together. This lung is stuck together. That's okay. That's not going to do it. Yeah. So it's going to take time to be able to get the gas moving into the lung. And one of the complex gas exchange mechanisms in the lung is something that's called pendula. You'll see here that we have a healthy lung unit, and then we have sick lung unit there. One of the advantages of high-frequency oscillatory ventilation over conventional mechanical ventilation is that for a given frequency and amplitude that's being applied at the airway, in the lung, the relationship is very different. The healthy lung units are going to see smaller pressures at a lower frequency. The sick lung units are going to see higher pressures at a higher frequency because it's pendling back and forth. The slow space is feeding the fast space is emptying into the slow space. So there's this really complex interplay between the healthy and the sick lungs. So that if I was to take this lung and actually bag it or put it on a ventilator, this whole process here would take twice as long, and you'd be ventilating all those sick lung units with a large volume. This way I'm using the small volume, I'm using a higher meteoric pressure, and in time, we start to recruit that lung. So let's say that this is a pediatric patient, and we've stabilized them on the high-frequency oscillatory ventilator, but the pH is less than 7.20. The PaCO2 is about 75. The bicarb is in the 20s, and the PaO2 on 100% is 55. What are some suggestions? Do we have a problem with oxygenation? Do we have a problem with ventilation, or both? Both. Okay. So what would you do to deal with the oxygenation issue? What's that? Oh, reduce the frequency for oxygenation? Okay. So we're going to increase the meteoric pressure because that might come next, though. That might come next. So we're going to try to increase the meteoric pressure, and by increasing the meteoric pressure, we're going to turn that up a little bit. So maybe 27 isn't enough. This is a larger baby. It's very sick. So I've gone up to 40. Even in like a term sick baby with pneumonitis, I've gone up to 40. It's not the pressure, it's the amount of volume that's being provided in the lung. But you should never really have to go much above 25 for most infants. So we've increased our meteoric pressure, and the PaO2 gets better, but we still have a problem with CO2 elimination. Remember I said the PaCO2 is in the 70s, and the pH is less than 7.20. So what would be your primary adjustment for CO2 elimination? Yeah, the deltas. So I'm going to go up. See that it's the stroke volume, the amount of pressure that's being applied is much greater. So now I've maximized my amplitude. It's a few hours later. I've turned that amplitude all the way up, and my PaCO2 is still 65 or 70 in this baby. What would you do next? And what would you decrease it? Yeah, so what would you decrease it by? 1, 2, 3? Let's do 1. Let's do 1. Okay, so we'll decrease that frequency by 1. See how it's wiggling a little bit more? You give that ventilator more time for the airway pressure to match the alveolar pressure. And in essence, you get a larger volume moving into and out of the lung. Okay? So that looks a lot better. Now I'm going to come along and I'm going to disconnect that baby and suction the lungs. Sats go down to the 20s. Okay? I got to hook that baby back up again. Oh man. And I'm back to square one. Okay? So my advice to you is don't disconnect the oscillator unless you absolutely need to. If their chest wall is not shaking, it's either they've got secretions or they've got a pneumothorax. If it's a baby and they start breathing spontaneously on the oscillator, it's likely that their carbon dioxide level is increasing, so they need to be suctioned. All right? But if I were you, any unit that has high frequency oscillatory ventilators, I would never disconnect them to suction. I would always use an inline suction catheter. Because with it, I wish I had an inline suction catheter to show you. You don't lose the volume improvement in the lung with an inline suction catheter like you would when you disconnect them. Right? But sometimes when I disconnect them from the oscillator, I'll turn their pressures up a little bit. Airway pressures up a little bit. Disconnect them and leave that pressure up a little bit higher for a few minutes and then wean it back down. Okay? So this is kind of a high-frequency oscillatory ventilator in a nutshell. You will find that in those babies, keep in mind, this isn't for everybody. Not every baby can be supported by HFOV, especially if you have a clinician who hasn't done it a lot. But the more you use it, the better you're going to get at it. If your pips start getting above 25 centimeters water pressure, it's a good time to use it. Some say that if you're really good with the oscillator, you can start it at pips that are even smaller than 25 centimeters of water pressure and have good outcomes. One hospital in the United States that has some of the best outcomes in the world for neonates uses the high-frequency oscillatory ventilator right from the first breath. So babies that require mechanical ventilation, rather than going on a conventional ventilator, they always go on the oscillator, so they become very good at it. But again, it's not for everybody, and kids that have lots of airway obstruction and a lot of mucus, you'll put these kids on the oscillator, and a lot of times, like with viral events, bronchiolitis, be careful because sometimes those kids need to come off and you need a bad suction because all that pressure is going to hold those secretions down in the lung. So be careful with those types of kids. And realize that in kids that have high airway obstruction, like meconium aspiration children, you may need to go way down on that frequency setting. I've gone down as low as 5 on a large newborn with meconium aspiration, just to be able to ventilate them. But if you can't ventilate them appropriately at that lower frequency setting, then it's time to go back to the conventional ventilator. Some kids just do better. So, what was that? Does that mean switch? Inhaled nitric oxide is used in conjunction with high frequency oscillatory ventilation. Very nice. Heliox gas, very nice to use that in kids with upper airway obstruction. We could talk about that a little bit more, but that's not a widely available resource right now. It's starting actually.
They are giving the single dose, sometimes the double dose.
Respiratory syncytial virus bronchiolitis, neuromuscular weakness, just chest muscular dystrophy or stress, post-operative patient who is not saturating very well, and really any type of acute lung injury that does not require huge support. I would guess that this use of
35 to more than 21%, we can use oxygen source to it. The maximum oxygen that we can deliver through this machine is around 35 to 40%. If more than that, we can use our conventional ventilators with the proper changes in it. We can use our conventional ventilators where we can deliver even 100% oxygen for non-specific oxygen. How this machine works? So this machine runs put it in AC current. This sort of a display you will get, and then various knobs of it. First thing that we need to select is the mode. Two modes, as you can see, is available here: the bilevel mode and a CPAP mode. So we can select what mode that we want to choose. So after selecting this mode, as Sir has told you that initially we should start with a low support without the CPAP. So we can choose the CPAP mode, allow the child to gradually settle down on this machine. We can start with the low pressures. We should sit with the child, explain them why this machine is important, how is it going to work, how the work of breathing is going to be. And once the child senses that, he becomes comfortable on that machine, and then you can gradually build up the pressure from the bilevel mode of the bilevel. After selecting the mode, we need to set the pressures as we have seen on the basic ventilator. Synonym of BIP is here IPAP, that is inspiratory positive airway pressure. Synonym with PEP is EPAP, that is positive air expiratory pressure. The trigger that we need to select, the trigger should be appropriate to synchronize with this machine basically. It should not be too low that the patient is auditory, it should not be too high that patient is not able to trigger. Oxygen is not in our hand, that's one of the knob over there, we can trigger the oxygen. After just selecting this BiPAP machine, which is for the acute respiratory problem, the saturation will be called transient because we will be giving the high dose injection by a non-breathing mask or something like that. But the most important thing that Sir has told you is the decrease in the bulk of breathing that we should monitor after applying this machine. So once we have done that, we should closely connect this interface to the patient's face initially for 2 minutes, maybe 2 minutes. Once they settle down,
In the pediatric world, we've been much more comfortable going past preset numbers. The adult world, if you got a peak pressure above 35, they switch ventilation or they just let you sit there. It was 2 kilo Tylenol. Too bad, so sad. I'm not going above 35. It became this written rule in stone. So with this, we can really ignore some of those things because we know that a lot of that pressure is going away in the airway. It's not really being transmitted to the alveolus. Now, is that what's happening anterior when you get to West Zone 1, upwards getting lots of ventilation and not as much perfusion? That's where a lot of criticism of transpulmonary pressure is that it doesn't measure the whole lung, it just measures that one place. And we are interpreting that being our target for that part of the lung is not a bad place to start. But over time, recognize that anterior lung is going to be a lower pressure, dependent lung a higher pressure. We're probably going to have different ranges for those. And over time, we'll figure out how to measure it. Right now, we don't. People are looking at measuring at the tip of the endotracheal tube. You know, there's a balloon at the endotracheal tube that we'll use as an esophageal pressure of sorts as well. Well, that's really measuring fairly high up in the airway. Probably still West Zone 2, but you're not measuring down by the heart. So it's a little bit more, you don't have the superseding structure of the abdomen and the heart to account for. So whether that number is a better number or just a different number is still to be determined. This is the cutting science right now of what we're doing with measuring what's going on inside the chest. And I think in your careers, in the next 20 years, you're going to see this is probably more likely to dictate what we do as opposed to measuring at the endotracheal tube, which we've done for 30 years. Questions about that? Or speak up. I still can't hear you.
Adverse effects or any side effects?
Are there side effects of measuring? Well, other than the mechanical aspects of things, because you have to go in the esophagus. Anytime you put a tube in the nose, you run the risk of sinusitis. The balloon is not high pressure balloon, so we don't have typically erosion or ulceration or things like that in the esophagus. These are meant to be gastric feeding, and in pediatrics, we like transpyloric feeding for a lot of our patients because reflux is such a big issue. You have someone with a big pendulous abdomen or someone with obesity or someone who has like an abdominal process going on, then it makes it harder for the gastric piece. A lot of those patients aren't being fed anyway, so sometimes this is really being used just for the monitoring device. But there are actually tubes being developed that'll be transpyloric tubes, and the esophagus balloon will still be at the right place. It's just harder to get a consistent measurement. Obviously, you can feed anyone in the stomach; it's still a stomach tube. But with transpyloric tubes, it varies on the size of the patient and how cleanly you get right into the pylorus. I can't hear you.
You can reuse.
No, I think, well, right now they're made for single patient use. And it's a very expensive therapy right now. And I think in a resource-limited place like India, these are one of those things you have to decide, is it worth it or is it not? There are selected patients, I think you're going to have a lot of results with this that will help. The whole point of hearing about it here is that in the course of your careers, you're going to see that these things become more common use. People are using it as the gold standard, and eventually you will need to transition to that to be able to provide the same level of care. Europe is typically a lot earlier in the process of this kind of thing than we are in the United States because of the approval for medical devices is much slower in the United States. So we often gather our data from European studies first, and they've used it more in adult and peds ICU. So this is very popular in France and Belgium and Germany. They're doing this much more commonly than we are in the United States because the United States is still getting through the process of being evaluated for the drug administration.
Is it applicable for one lung ventilation? If you're using it for one lung ventilation,
For one lung ventilation?
is it applicable? Like, can you use this?
I don't know that. I don't think it's probably got some animal models to support that, but I don't know. Because you're really measuring in the center, and you may be sort of having to average what's happening in a non-ventilated lung and a ventilated lung. If you're not getting good deflection on your pressure forms, there's a good chance it's dampened because that other lung is not working. Say you get a pneumothorax, the same kind of thing as one lung's being ventilated, the other one's not, but your pressure's high on this other side, then it typically will show in your transpulmonary pressure. But when it's underventilated, I don't know what that would do.
What's that?
What's that? Is there what? Oh, other ventilator types. Right now, this is their baby. They make it.
There was a product called Bicor out a few years ago, and as Care Fusion as it was before, bought Bicor and put the hardware and the software in there. So it's all.
If you look this up, there's YouTube demonstrations of this on patients. Care Fusion is the company that does this right now. There's other in development that will be getting this over time, but right now it's their patented technology. And so it has to work with the graphics of a ventilator. So not only do you need this, but you need the graphics ventilator or via ventilator. And so it's a bundle procedure, much like when I talk later today, I'm going to talk about airway pressure release ventilation and proportional assist ventilation. Those are all special types of ventilation. Some ventilators do it, some don't. And that's one of the things when you go buying ventilators for your unit, you have to decide how are you going to use them. Some ventilators really are.
Make sure the patient is not maintaining gas and developing a large audience. And you can do that with a chest x-ray. And the big thing that this does, when you apply it, breathing rate will decrease. You'll see that right away. And that's the rate of your breathing is the biggest risk factor for air trapping and pneumothorax because Yes, and the neonatal unit uses, our neonatal intensive care unit uses these devices on this device also. So it works. It has been said the most important thing is having a variety of sizes of masks. But so it has been utilized in patients with asthma, and you just have to be careful as you do with invasive mechanical ventilation. Air trapping is not but it can't be used. It just, both may be helpful. This has an advantage that it can provide inspiratory support as well as continuous positive and negative support. So if the patient's hypoventilating, this is better. If the patient is spontaneously breathing, it just needs a little help. And the bubble CPAP, that's great. It works. This has the extra advantage of an inspiratory support as well.
discovering, at least in the early studies, is that they're using much more generous airway pressures to achieve a better number, and those patients get better ventilation, they get lower FiO2s, and they're able to